have great pleasure in welcoming all faculty delegates who have logged in from all over the world for this international webinar. I am Dr. Chandrasekhar, your ACG Governor of India region. I bring warm greetings from American College of Gastroenterology as an endorsed ACG endorsed webinar organizer. I bring warm greetings from World Gastroenterology Organization as a member scientific committee and from our university, Dr. MGR, Tamil Nadu, Dr. MGR Medical University, and our organizing unit, MedIndia Hospital and Academy. The first 4 series of webinars saw the participation of over 24,000 delegates from all over the world. Now you tell me you will not be inspired to do this for 5th series of webinar. The two ACG with the ACG endorsement is what we carried out. The next webinar series, that is the 5th webinar series, starting from April 2025 to March 2026. Now, after that, we are going to go further also. And we give a nice tagline, the name, the topic, the word experts are here with another important message that new Endo-GE webinar series. This webinar series was inaugurated by none other than Professor Dr. Jonathan Leighton, President of American College of Gastroenterology then. And after that, we have seen participation of the stalwarts, including the Nobel Prize winner, Professor Dr. Barry Marshall, the discoverer of Helicobacter pylori. And he gave a fantastic topic on his journey of discovery of Helicobacter pylori. And further, over 9,000 delegates from all over the world attended the webinar. Then we got more visibility and got importance. These webinars are appear to be very important one among the gastroenterologists. And I must thank my colleagues, Dr. Gokul, Satya, Yogesh, Prasad, TNS, and our international medical director, Dr. V.T.C. Vivek Sandeep, for helping me to organize this webinar. And these webinars have been now organized. We are going for the 6th series from November onwards. And this webinar became very prominent and very important because of the participation of several national faculty, who is who in gastroenterology across India and across the globe. And we see the international faculty who all participated. And we have the strong patronage from the leaders in gastroenterology, not only from India, neighboring countries, and from all over the world. And all middle-level gastroenterologists agreed to be the moderators and panelists. It is impossible to tell everybody's name, but it has become so popular because of their contributions only. We started the 5th series with the neuroendocrine tumor, then GIS, then optimizing before liver transplantation and the post-transplant care and diarrhea and immunocompromised host and irritable bowel syndrome. And now, then how did I arrive at the MELT score from none other than Patrick Ahmed, who is the discoverer of the MELT score and clinics in alcohol-associated liver disease. Now, currently in August, ulcerative colitis. What is the management 2026? And Crohn's disease, what's the management in 2026? Dysbiosis and GI disease will be by Dr. Nageswar Reddy next month. And another very important topic is antibiotic. Right choice and rational in GI infection, pancreatitis, and liver disease by Professor Dr. Usha Datta. And we are going to have a debate kind of thing, acute pancreatitis, natural history, complications, management, chronic pancreatitis, natural history, complications, and management. And we are very glad to inform you that Tamil Nadu Medical Council has recognized and accredited with one credit hour for all the attendees of this program. And today is going to be a very important day. The reason why is IBD is increasing in incidence and prevalence in India, and both ulcerative colitis and Crohn's disease, number one reason. Number two, there's a sea change happened in the management of ulcerative colitis and Crohn's disease. What it was 10 years before and now is totally different now. You can't have the old treatment now for the newly evolved, the kind of complications what we are seeing is. And we have eminent faculty and equally eminent the people, key opinion leaders as moderators. And it's my pleasure and duty to introduce my faculty now. Dr. Vishal Sharma is additional professor from one of the premier institute of India. I had to introduce the reason is I'm also from PG Chandigarh, and we have delegates from all over the world. And his areas of interest, inflammatory bowel disease and gastroenterology tuberculosis. He is the editor-in-chief of Journal of GI Infections. He is the recipient of S.R. Nayak, the prestigious Memorial Award from Indian Society of Gastroenterology, and the number of publications you see to believe it now. And we have Dr. Jill Gaidos. She is the Associate Professor of Medicine, Yale School of Medicine, Connecticut, USA. Yale School of Medicine is one of the important institute everyone will dream to go and visit the Yale University. And a medical director of clinical research, underline the word clinical. That's the reason I appeal to her just before starting the beginning of the program. We would like to have an associated for the multinational projects. Your inflammatory bowel disease program, and naturally she has got a publications in inflammatory bowel disease. Another stalwart from India who is really a face of IBD in India, and he represents India wherever he goes. As far as the IBD is concerned, Professor Dr. Vineet Ahuja. He is a professor, Department of Gastroenterology, another premier institute of India, All India Institute of Medical Science is the New Delhi. His area of interest, he had initially wide area of interest, including amoebic liver abscess. I've seen in some of his publications. Now he is focused on inflammatory bowel disease. He is recipient of several awards, including CM Habibullah Oration Award. He is the editor-in-chief of JCH Open Journal, and publication and H index is quite incredible now. Another very good friend of mine is a very silent worker and but very deep, intense interest in IBD and hepatitis C is none other than Professor Dr. Ajit Soul. He is heading the Department of Gastroenterology, Dayanand Medical College and Hospital, Ludhiana. He is the founder of Colitis and Crohn's Foundation of India. They are doing excellent work. They have an immense contribution to our country. And he is the recipient of B.C. Roy National Award, and his publications also quite incredible. Equally eminent doctors in the field who are really showing a lot of interest in IBD is my good friend Dr. Sarojini Parameswaran. She is also a consultant gastroenterologist at Apollo Main Hospital, Chennai. And my colleague Dr. Satyamurthy, he has got a wide interest in endoscopy and IBD too. And he's from represent Med India Hospital. Another junior colleague of ours who is active in practice, clinical practice, is Dr. B. Vinod from Kadalur and periphery. Why we have chosen one from periphery, metros, international, national, to give a wide spectrum of our orientation and real life experiences there. These programs would not have been popular or would have been useful to everyone without the help of our national ambassadors coming from Arvind Gubbi from Karnataka, Praveen Kumar from Kerala, and Chaubal, and Girish Kumar, and Jharkhand, we have Jain Ghosh, and everybody is there. And we have equally important international webinar ambassadors also representing various countries mentioned here. I think with this introduction, I just want to draw your attention to invite you for our live workshop, which has been endorsed by American College of Gastroenterology in February 26, 27, 28 at Taj Coromandel to see the live program in action with equally important the master videos and other programs and the exciting scientific program. With this, now I declare open the session will start the lecture session. Now I invite Professor Jill to introduce the topic and invite the first speaker, Dr. Vishal Sharma. Dr. Jill, over to you.
Thank you so much. Thank you so much for inviting me to participate in this amazing panel of faculty. And I love the excuse to talk about inflammatory bowel disease as much as possible. So I'm very happy to be here. It is my pleasure to introduce Dr. Vishal Sharma, who will be presenting ulcerative colitis management in 2026.
Thank you, Dr. Chandrasekhar sir and Dr. Jill for having me on this very important webinar. Are my slides visible?
Yeah,
Yes.
fantastic, fantastic.
So we have got quite a bit of ground to cover over the next 30 minutes, and we will talk about how the paradigms are changing as far as treatment of ulcerative colitis is concerned. These are some of the areas I will touch upon, but because we have only 30 minutes, I will not talk about preventive care, pouchitis, or extraintestinal manifestations. So I'll start off with the poem, the two famous quotes from this poem by Robert Frost. Something there is that doesn't love a wall, and good fences make good neighbors. And while both of these are true, they are very, very opposite to each other. And the two themes which I want to focus on today, while we talk about ulcerative colitis, are also opposing themes. Most patients with ulcerative colitis run a mild course of disease. Also true is that treating ulcerative colitis or IBD in general is becoming more and more complex. So this is a pictorial representation of data from population-based cohorts. And you can see that a large number of patients with IBD or with ulcerative colitis can easily be managed only with mesalamine. However, a small number will need to be on advanced therapies or need colectomy. And over a 10-year period, almost 2/3 of patients will just require 5 ASAs, and only 10% will need a colectomy. So this is, overall how patients behave. Over the last few decades, we have seen an incremental rise in the number of therapies that are available. Initially, while we only had 5-ASAs, steroids, and thiopurines, we now have an ever-increasing number of biological and small molecule therapies. And of course, their use is increasing in the treatment of ulcerative colitis. Once a diagnosis of ulcerative colitis has been secured, we embark on assessing the disease and treating it. So what are the pre-therapeutic evaluations that are needed? So obviously, after a diagnosis has been, a multimodality diagnosis has been achieved using clinical features, endoscopy, and histology, we need to evaluate the extent and severity, presence of EIMs or any complications, patient's socioeconomic status, so that the best therapy can be chosen, preferences of the patient in respect to the therapeutic goals, risk tolerance, and the preferred route of administration, and of course, our own experience and comfort with the available therapies. So why is extent evaluation important? And this is Montreal classification, dividing ulcerative colitis into either a proctitis, which involves a rectum, a left-sided disease, or an extensive colitis, which goes beyond the splenic flexure. Now, this is important because it can help us choose the therapy of choice, prognosticate these patients with E3 probably performing worse, decide on the risk of dysplasia and choose surveillance intervals, and the follow-up monitoring strategy for these patients. So we know that ASAs are the bedrock of management for mild to moderate disease, And we try to use the colonic preparation or the colonic release preparation. The MMX preparation is not available in India, but we do have availability of sulfasalazine and pH release formulations, which largely deliver the drug to the colon. When the disease is largely in the rectum, a suppository may be of great use, and typically other preparations like enema, etc., can be combined with oral formulations to increase the amount of benefit. Now, coming to assessment of severity, typically what we use is a complete Mayo score, which takes into account assessment of stool frequency, rectal bleeding, mucosal appearance on endoscopy, and a rather subjective physician global assessment. And as far as endoscopy is concerned, you can see here that it is either normal or inactive disease. You can have some amount of loss of vascular pattern. Presence of erosions is scored as 2, and when you have either ulcers or bleeding, you score it as 3. Another endoscopic score, which is now being used much more often, is the Ulcerative Colitis Index of Severity, and it takes into account 3 parameters: the vascular pattern, the amount of bleeding, and the presence of erosions or ulcers to define the endoscopic severity of ulcerative colitis. Now, once we have seen the disease activity, we want to understand why the disease is active. And obviously, it is largely because of the intrinsic behavior of the disease, but there could be a lot of additional factors which might be contributing to the disease activity. One of which may be lack of adherence, which is very common because even ASA preparations can be very costly for some of our patients. Then enteric infections, especially Clostridium difficile, can be cause of a flare. When patients have largely a proctitis, it is important to exclude sexually transmitted infections, and certain drugs like NSAIDs or antibiotics may result in a flare or sometimes even increase the risk of Clostridium difficile infection. So certainly when we are dealing with a flare, a stool culture and examination is mandatory. In an appropriate setting, a amoebic serology may be helpful. And certainly we would want to test for Clostridium difficile and also exclude CMV in an appropriate setting. So this is a summary of most of the studies from India. And as you would note that the prevalence of C. diff related flares in ulcerative colitis is on the lower side. So this is data from Delhi and from our own center, which shows that overall prevalence is low. There are a few centers, including DMC, which report a relatively higher prevalence of Clostridium difficile. But if you look at this systematic review that we did, most of the events of Clostridium difficile have been in acute severe setting rather than moderate ulcerative colitis. So in a resource-limited setting, when we are suspecting a flare because of Clostridium difficile, and that would typically be in an acute severe setting, we can limit the initial testing to GDH rather than 2 initial tests, which the Western guidelines suggest. And if the test is positive, we can go ahead with the second test to be sure that it is indeed Clostridium difficile infection, which is NAT or a toxin assay. Now coming to CMV, CMV should only be suspected in appropriate setting, and that is largely when you have a steroid refractory thiopurine exposed patient who is not responding to immunosuppression. Again, there can be a spectrum of presentation from just an infection to a GI disease and a disseminated CMV. We would need to stop IBD therapy only in disseminated CMV, and we may want to treat for CMV with ganciclovir when we have a high burden of disease in the GI tissue. Again, data to support ganciclovir therapy is rather conflicting, and over the long term, the colectomy rates do not really seem to improve. Now, coming to other enteric infections, which may be a concern in a country like India. So this is a recent systematic review where we noted that the positivity of a multiplex GI PCR was as high as 30% in IBD, and it was much higher in patients who had flares. Over the short term, there was a lower odd of IBD therapy escalation if the PCR testing was actually used. But the problem is that all of this is retrospective kind of data, and there's no randomized trial which has evaluated the use of these panels in management of patients with ulcerative colitis flares. Now, coming to treatment of ulcerative colitis, so it is important to categorize the disease activity into either mild to moderate, which is relatively lower frequency of stools, maybe less than 4, with some amount of inflammation in the colon. On the other hand, we have acute severe ulcerative colitis, which apart from a high number of bloody stools, typically more than 6, we also have systemic inflammation. And somewhere in between, where we don't have systemic inflammation but have significant increased stool frequency and colonic inflammation, we call it moderate to severe. Now, before we go to the actual therapeutic strategies, there are certain paradigms which have shifted. The ECHO guidelines clearly state that there is no need for patients to have failed, proven intolerant, or have contraindications to conventional therapy to go on to advanced therapies. So all therapies of all kinds should be available to our patients, and the appropriate therapy should be used in an individual patient. Obviously, a lot of things go into making these decisions. Apart from disease severity and the extent, we also need to consider the effectiveness of individual therapies, the time to onset of action, the costs, very important in our setting, risks, adverse events which can happen with these therapies, and obviously with access to biosimilars and generics, whether they are the appropriate choices rather than the originators. And obviously in some subset of patients, we might be talking about combining advanced therapies in a difficult to treat kind of situation. So first, let's quickly go over mild to moderate ulcerative colitis, which we already defined. So if we have a proctitis or a disease limited to rectum, it may be appropriate to use a classical step-up approach using initially a rectal preparation, a suppository, and adding oral ASAs in those who do not seem to respond. The next step could potentially be steroids with thiopurines, and obviously biologics and small molecules as one of the later steps in the management of proctitis. When we talk about left-sided or extensive colitis, the initial therapy would best be a combination of oral ASAs with topical mesalamine, and then we can, in patients who do not respond, use a MMX preparation of budesonide. Again, if it is considered to be costly, we can give the standard systemic steroids. And of course, if the multiple courses are needed or a dependent kind of disease, thiopurines can be used. And the next part of the ladder can be the biologics or the small molecules. Now coming to moderate to severe ulcerative colitis. So if we talk about this particular severity, here the changing paradigms have been reflected in the guidelines. So in general, in patients who were naive to thiopurines, the typical strategy would be induction with oral steroids, and which is typically prednisolone, and maintenance with thiopurines. But of late, people are concerned about adverse effects which can happen with steroids, which would include those related to bone health, hypertension, cataract, etc. And obviously, some of the concerns with thiopurines like cytopenias and unpredictable injuries like pancreatitis or liver injury. And obviously, there is limited efficacy of thiopurines, and now we have affordability in respect to advanced therapies. Another important thing to note is that in the setting of thiopurine use, and this was a randomized trial which we recently reported, where we compared a long taper regimen with a short taper regimen, 10 weeks of total steroids versus 6 weeks. And you can see that steroid-free clinical remission at 6 months was higher in a longer taper of steroids. Again, this means that in a setting where thiopurine is used as a maintenance, steroids would probably have to be given over a longer period of time. Therefore, there is a shift in the paradigm. The ECHO and the AGA guidelines do not need a failure of conventional therapies, and the AGA actually suggests advanced therapy after failure of 5-ASA. The step up obviously is evidence-based and probably cheaper. Top-down, on the other hand, would go in accordance with the treat-to-target approach, and the regimens are relatively simple, that you use the same agent for induction and maintenance. In our context, top-down may not always be possible because of costs and availability of drugs. So if we have a steroid-dependent and a thiopurine refractory disease, or if we have a high-risk disease in young people with deep ulcers, multiple hospitalization, and we may consider advanced therapy upfront. What are the approved advanced therapies? So you have TNF inhibitors, and we have infliximab, golimumab in India, and a Adali biosimilar. Anti-integrins like vedolizumab, which is available in India, anti-IL-12/23 with ustekinumab, again available in India, anti-IL-23, which are now coming up, and guselkumab has received approval and should be available shortly. JAK inhibitors, again, we have tofacitinib and upadacitinib in India, and we do not have yet an access to S1P modulators. It is important to note that while these agents can all be used for induction and maintenance, guselkumab gives us an option of both an IV and subcute induction dosing strategy. So when we choose between these agents, we look at efficacy, we look at speed of action, we look at safety, and we look at the costs. So we have one head-to-head trial which compared adalimumab with vedolizumab. I'm not talking about other head-to-head trials like with the drugs like etrolizumab, etc., because they are not really approved. So in this trial, you can see that vedolizumab seems to be outperforming adalimumab, except for steroid-free clinical remission rates, which seem to be numerically higher in adalimumab. And the risk of infection was lower in vedolizumab. Because of lack of direct head-to-head trials, how do we choose a therapy one over the other? Now, this is data, this is from the Living Guidelines reported. First author is Sid Singh, and this is from a network meta-analysis which they did. Now, the problem is that here you don't have head-to-head data, but data against placebo, and you statistically arrive at a conclusion, or let's say a probability of a particular therapy being most likely to be the best, and then order them in a particular fashion. So high efficacy therapies in individuals who have not been exposed to advanced therapy are infliximab, vedolizumab, and risankizumab and guselkumab, and of course JAK inhibitors, and ozanimod and etrasimod. A lower efficacy drug is adalimumab, and usually the guidelines suggest against using this therapy. Now, when you come to advanced therapy exposed, and this is largely data for patients who have been exposed to TNF inhibitors, you have high efficacy drugs, and amongst biologics, it is ustekinumab, and JAK inhibitors seem to be very good in this setting. Vedolizumab now comes to a lower efficacy agent, and adalimumab stays on there, and certainly the S1P inhibitors also modulators also come to the lower efficacy group. So the choice of therapy can be different depending upon whether the individual is advanced therapy naive or exposed. Coming to the speed of action, again, this is SUCRA ranking from a network meta-analysis. And to summarize, we have biologics like infliximab, which is very fast acting. We have JAK inhibitors, which are again fast acting, and of course steroids. And as far as slow acting drugs are concerned, we already talked about thiopurines, but vedolizumab is also relatively slow acting. So if we need speed of action, obviously we can understand that steroids, JAK inhibitors, and TNF inhibitors are agents of choice. Now, what about concomitant medication? And this is an important question, that what to do with the therapies, ongoing additional therapies. And this is again a recent data which suggests that ongoing use of mesalamine really does not impact remission rates. Similarly, concomitant use of steroids along with advanced therapy does not impact the remission rates with advanced therapies. What about thiopurines? So certainly with infliximab, because it can reduce formation of anti-drug antibodies and reduce the immunogenicity, it is appropriate to use thiopurines at least initially, even if it is in low dose. Data is conflicting or not very certain for adalimumab. For vedolizumab, the VIEWS trial actually showed that the primary outcome was not different, but there was some difference in the fecal calprotectin. So probably we may not want to use, but again, we are not very sure of the estimate. Ustekinumab, probably not of benefit, and certainly for JAK inhibitors, we would rather not combine thiopurines with JAK inhibitors. Now, let me summarize. For first-line efficacy, we have infliximab, vedolizumab, upadacitinib, S1P modulators, and risankizumab and guselkumab, and adalimumab is a lower efficacy drug for the first line. For bioexposed, JAK inhibitors, upadacitinib, tofacitinib, and ustekinumab are high efficacy. Adali and vedolizumab are low efficacy. As far as speed of onset is concerned, Vedo is relatively slow acting, and anti-TNFs and JAK inhibitors fast acting. Cost very low for generics, which are available in India, and of course biologics, because of the way they are manufactured and the way they are stored, they are high. Risk of infection, TNF inhibitors, very high risk for TB. Also for JAK inhibitors, zoster and TB. And in countries like India, there's no going away from risk of TB with practically each of these therapies. Theoretically, there may be a risk of progressive multifocal leukoencephalopathy with S1P modulators. And in comorbidities, the safer drugs may be vedolizumab and ustekinumab. Again, oral administration helps make JAK inhibitors an attractive therapy for some of our patients. EIMs, vedolizumab may not be of benefit, and immunogenicity is a significant concern with some of the TNF inhibitors and not a concern with oral small molecules. Now coming to monitoring in patients with ulcerative colitis. And if you see, then we can use one of the clinical scores, typically PRO2. We can also use non-invasive testing, and this typically combines CRP, fecal calprotectin, and a lot of data for bowel ultrasound with things as simple as bowel wall thickness, which can be helpful, and obviously the invasive gold standard when there is discordance between the non-invasive tests. Frequency of monitoring will be based upon the clinical condition, more frequently when disease is active and relatively infrequently when the disease is in remission. In patients who do not respond, there is an escalation ladder. One could potentially optimize the current therapies, maybe increase the dose or reduce the duration between the doses. However, if we need to act fast, we may escalate to another drug, and in dire situations, we may choose addition of steroids. Now, who are the patients who need hospitalization? So we need to hospitalize patients with acute severe ulcerative colitis where there is systemic toxicity, patients with severe or massive bleeding, toxic megacolon, perforation, and significant complications associated with a flare. Now, acute severe ulcerative colitis is diagnosed on the basis of TULIP widths. There are other criteria, but TULIP widths is the one which we use typically in the clinics with bloody stools of more than 6 and any one of the features suggesting systemic inflammation. How do we prognosticate these patients? So at admission, an ADMIT ASC, which combines albumin, CRP, and an endoscopic severity grading can be helpful. On treatment, typically what we use is an Oxford index at day 3. So how do we manage acute severe ulcerative colitis? So we do the standard evaluation, including stool examination, testing for Clostridium difficile. We go ahead and do an unprepared sigmoidoscopy, taking biopsies for possible CMV and an abdominal X-ray to look for megacolon or a perforation. IV steroids, along with DVT prophylaxis, will be the standard of care which need to be given to every patient. And for steroids, the choice can be between hydrocortisone and methylprednisolone. So this was the landmark TACOS trial combining tofacitinib to IV corticosteroids, showing that a combination is better than steroids. But we have data which is unpublished and under review from an AIMS trial, which suggests that the two strategies would be equal or similar. Now, this is again data from exclusive enteral nutrition again from All India Institute of Medical Sciences, where 62 patients were randomized to standard of care, which is IV steroids and standard nutrition, or to exclusive enteral nutrition. And you can see that while numerically the steroid failure rates fell, but there was no statistical difference between any of the predefined outcomes. Now, there are certain interventions which have been tested but don't seem to be work. This was our trial with antibiotics in acute severe colitis, no difference. Albumin, again from AIMS, no difference. And this was oral mesalamine in acute severe ulcerative colitis. In the Combo-Misa trial, again, no difference between the standard of care versus addition of mesalamine to standard of care. So we can possibly combine JAK inhibitors or give EN. Again, we are not very sure of this, and certainly we don't need to use oral mesalamine, antibiotics, or albumin. We assess again on day 3 using Oxford. If a stool frequency is more than 8 or 3 to 8 with a high CRP, these patients are at a high risk of colectomy and should ideally proceed to a second line. We have 2 randomized trials. Nothing to really separate these 2 therapies. Cyclosporine versus infliximab seem to be comparable. Although people tend to use infliximab, but cyclosporine remains an effective therapy as far as second line is concerned. Now, people also feel that a higher dose may be better. This is the only randomized trial which tested infliximab dosing in acute severe colitis, 2 steps of randomization. Patients with refractory acute severe ulcerative colitis received either 10 milligrams or 5 milligram. And the 5 milligram were re-randomized to a standard induction at 0 to 6 or an accelerated induction at 0, 1, 3, and really nothing to separate these arms. So in general, for most of the patients, it is reasonable to use a 5 milligram per kilogram dose as of now. Now, coming to cyclosporine, although this seemed to have fallen out of fashion, but now it can be used even in patients who have been thiopurine exposed, and they can be bridged over to the newer biologics like vedolizumab and ustekinumab. And the traditional contraindications may not apply with lower dose because 2 milligram per kilogram is safe even in patients with low cholesterol, as shown in our small series of patients. Another option which is gaining currency is JAK inhibitors in acute severe colitis, typically used at a slightly higher dose, maybe 10 TDS for tufacetinib and 30 BD for upadacitinib. And you can see that in this systematic review done by our group, there is actually no difference between the response rates between these 2 therapies. Of course, this is not the last word, and we are awaiting some observational comparative data, which might change our current thinking about this. So we have infliximab, cyclosporine available as a second-line therapy, JAK inhibitors possibly another therapy which can be used, and we are not very sure. In fact, the evidence doesn't support the use of high dose or frequent infliximab. And then if patients do not respond to second line, they should ideally go for a colectomy. Third line medical rescue, there is some data from retrospective studies which show that it may work in a subset of patients, but it will remain a risky strategy for most of our patients. Before we move forward, I'll briefly talk about the active trial, which had patients with acute severe ulcerative colitis who responded to steroids and were randomized to either azathioprine or infliximab maintenance. And you can see that steroid responders did well if they were randomized to infliximab. And the steroid could actually be stopped very quickly. So steroid stewardship in acute severe ulcerative colitis should avoid mega doses, should avoid prolonged steroids initially. Those who are steroid responsive, if thiopurines are used, we need to use a longer taper. If infliximab or JAK inhibitors are used, we can probably stop steroids early. And JAK inhibitors are better than thiopurines in this propensity matched analysis from DMC. Surgery is typically reserved for those who are refractory, acute severe ulcerative colitis, medically refractory disease, and patients with dysplasia or colorectal cancer. Now, for a few minutes, we'll just talk about some additional issues which are important in ulcerative colitis management. So strike 2 targets for ulcerative colitis, which are not really based on a lot of data. So they recommend looking for a clinical response, a 50% reduction in PRO2 in the short term. In the intermediate term, maybe over 6 months, 3 to 6 months, one should look for clinical remission and biochemical remission with reduction in CRP and calprotectin. And over 1 year or so, one should aim for an endoscopic healing. And improvement in quality of life. The verdict trial, the results of which are awaited, might inform our strategy in patients with ulcerative colitis, whether we need to treat for symptoms, endoscopic healing, or histologic improvement. Now, some ancillary therapies. Curcumin has been shown to be beneficial in ulcerative colitis, and there are a couple of studies from India, AIG, and AIMS, which have contributed to this systematic review. Now, indigo, there are two well-done trials from Japan, which suggest that indigo is beneficial in ulcerative colitis. And now there is a combined formulation of curcumin and indigo, which is coming up. For fecal microbiota transplant, although the ECHO guidelines do not make a recommendation, but we have data from DMC and All India Institute, which are supportive of its use for induction and maintenance of remission, maybe along with a dietary intervention. And this is being further tested in randomized trials across ulcerative colitis, various clinical situations led by Professor Vineet Ahuja. An important recommendation which has come up by ECHO is that they have suggested laparoscopic appendectomy as an option for therapy refractory ulcerative colitis. And this is based upon ACCURE trial and COSTA study. ACCURE trial, patients in remission who underwent appendectomy, the 1-year relapse rates were lower. And in COSTA study, patients who underwent a lap appendectomy or were shifted to JAK, those who were on appendectomy had a higher clinical remission at 12 months. Now, difficult to treat ulcerative colitis is where multiple mechanisms have failed, at least 2 mechanisms, which may be across biologics or small molecules. And the strategy to help these patients is to break the therapeutic ceiling, which is typically over a remission rate of around 30%. And this is by combining advanced therapies. And this has been shown in the VEGA trial that combination of golimumab and guselkumab was better than, numerically better than each of these monotherapies. There was a VITO trial from AIG, which showed that combination of vedolizumab and tofacitinib was helpful. Another study comparing upadacitinib combination with vedolizumab against vedolizumab in ulcerative colitis, published in CGH, showed that combination was better. And early results from DUET-C UC suggest that a combination in bio-exposed patients was better than guselkumab alone or golimumab alone. So this suggests that combined advanced therapy may be helpful in a subset of patients with difficult to treat IBD. Lastly, a word about de-escalate. De-escalation is always risky, so we may want to avoid if possible. Again, we would need to de-escalate in a subset of patients, and cost may be an important concern. So ideally, we should de-escalate if there is high histologic remission. If not, if there's an endoscopic remission, and still we de-escalate, obviously, anybody who we de-escalate remains on follow-up. De-escalation trials, there are a couple of trials, Hayabusa and BioStop, which looked at ulcerative colitis. And you can see that for the primary outcomes, which was clinical remission, and endoscopic remission in these trials, you can see that there were differences which could be detected at follow-up. So certainly, we may want to continue therapy rather than stop as far as possible. So to summarize, we need to define the disease extent and severity. We need to discriminate the cause of flare. We need to personalize therapy based upon effectiveness, cost, severity, and preferences of patients and clinicians. We need to discuss with patients on the choice of induction and maintenance of remission. There is a need to avoid unnecessary steroids in ulcerative colitis, and timely reassessment and decisions regarding continuing or changing therapy are helpful. Thank you.
Vishal, that's a fantastic talk. And I think we are going to take up questions after the second lecture is over. Dr. Jill, I would like to make a brief comment before we start the second lecture so that all the questions related to ulcerative can be taken up after the 2 lectures.
Yes, absolutely. That was a wonderful talk. It's hard to cover everything you want to cover in 30 minutes related to ulcerative colitis, but it was a great, you highlighted all the key points, and I'm looking forward to our questions and discussion from the audience.
Okay, right. Then I will call upon Dr. Ajit Sood forward and introduce the topic and invite a second speaker, Dr. Vineet Ahuja.
Thank
Dr.
you.
Ajit Sood.
Thank you, TSC. We move on to Crohn's, and for this we have Professor Vinit Ahuja, who is a professor, Department of Gastroenterology at AIMS Delhi, and he is the Secretary of Practice Crohn's Foundation India. And I think there's no state in the country where he's not really lectured. And I really fondly called him as a great teacher on the wheels. And as like so many other people, we always look forward to listen to him, and we're really privileged to have him here. Dr. Vineet, please. Silent. Mute. Leave Vineet.
Can you unmute yourself, Vinit? Unmute yourself.
Okay.
You can start
I
from the
think-
first slide.
I think
Okay.
I should start again by thanking you.
Yeah.
That is very, very important. Number one, I have to thank you, Dr. Chandrasekhar, not only because you have invited me for this series of lecture, but also for being the most dynamic ACG governor we have had. It's a pleasure to have you as the ACG governor, and there's a great lecture series which is benefiting everyone. And thank you, Dr. Sood, for being my chair. Pleasure to have the best man in IBD to have you as your chair. Now, 2026, I think what we have learned about mainly is war. Like it has been a year of war. We have been learning a lot about war and warfare for sure, if not anything else. And it has been quite a learning when it comes to war because war for us was a man-to-man combat. And suddenly you realize that the rules of engagement had changed. It's no longer a war-to-war combat. It is like drones, it is precision strikes. In fact, like army doesn't even seem to be reaching till the border, and then the engagements are taking place. Crohn's disease is no less than a war, and it has been quite a terrific engagement over last 2 decades between inflammation and anti-inflammatory agents. However, it is time now that we look at Crohn's campaign in 2026, which seems to have shifted from conventional to modern warfare. And regardless of whether it is conventional or modern, I think for India, the first strategy still remains: have you identified your enemy correctly or not? Is your diagnosis definite or not? And for that, there's a very simple line I would coin, that is, not every fire in the gut is Crohn's. We have had a lot of masqueraders. Intestinal tuberculosis has been one. But right now, I would like to discuss another masquerader which we saw recently, and that is endometriosis. In every talk of Crohn's disease, I discuss one masquerader because we end up burning our fingers, even in a tertiary referral center with such a case, and we feel it's our duty to inform everybody that these are kind of cases whom, if your mind is not thinking about, you may end up missing and diagnosing in Crohn's disease and treating with advanced therapy. For endometriosis, there's often a 7-year diagnostic, average of 7-year diagnostic delay can occur. These are females who may present with intermittent diarrhea, rectal bleed, abdominal ultrasounds may not show any abnormality, upper GI colonoscopies, they may show non-specific erosions, and only if there's index of suspicion is high, you refer for a gynae examination, then somebody may pick up an endometric nodule. The symptom network is very deceptive. Irritable bowel syndrome, inflammatory bowel disease, endometriosis. They may have quite a lot of common symptoms like abdominal pain, bloating, diarrhea, constipation, and if endometriosis has a mucosal component, they may also have rectal bleed. The trap is that endometriosis is something which is localized to serosa and muscularis propria mostly. Whereas IBD, as we all know, starts in the mucosa. So if you do a colonoscopy and take a mucosal biopsy, most of the times it would end up messing up endometriosis. It's only when you suspect it and get a transrectal ultrasound or a transvaginal ultrasound, followed by MRI, deep disease mapping protocol, one may be able to pick up the endometric nodules. Surprisingly, even if it is involving the mucosa, many a times it is labeled as IBD because on pathology, biopsies may show IBD like chronic colitis changes, crypt distortion, lymphoid aggregates, and fissures. The solution lies in immunohistochemistry. Accurate diagnosis requires that you talk to the pathologist and get it stained for estrogen receptor, progesterone receptor, CD10 and CD68, and there you should be able to make the diagnosis. Tuberculosis, I'm not talking about because we have discussed it ad nauseum in many forums. I've just put up out here a gastro grand rounds, which has been written by 6 of us, including Vishal. So if anybody wants to go through it in detail, they can go through the gastro grand rounds out here. So in the war against Crohn's, the next strategy is that you would like to direct operations towards a clear decisive goal. That is how wars are won, and that is how war against the Crohn's is going to be won. And that is straight to guidelines. Vishal told you about straight to guidelines, and he gave you a very pragmatic view that in ulcerative colitis, we are not very sure that straight guidelines in the sense that how practical they are, because there is no randomized control available in ulcerative colitis as yet to back it up until the data from verdict trial comes out. In Crohn's disease, the situation is opposite. We do have some amount of randomized control trial, the initial CALM study, etc., which suggests that treat to target and stride to consensus may be helpful in terms of changing the disease course in a patient with Crohn's disease. What stride to or treat to target approach means that initially you would like to, in short term, less than 3 months, you would like to look at improvement in clinical symptoms, like the patient related symptoms like 50% reduction. Within next 2 to 3 months, you would like that clinical remission, Harvard Bradshaw index going to less than 5, normalization of biomarkers like CRP, fecal calprotectin between 100 to 250. And by 6 months or 9 months, you would like to look at endoscopic remissions in terms of SCS-CD less than 3 or absence of ulceration. And finally, even look at QL and disability, which could also be amongst the endpoints. Histological healing, transmural healing is still not considered as an endpoint. Third strategy, precision of strikes. Important for war, important for our war against Crohn's disease. And here precision of strikes is with the help of advanced therapy, that is biologics and oral small molecules. And if you look at various agents which are available, Vishal has given you a beautiful overview about the agents which are available in terms of what are the contraindications for them, what are the side effects for them. Here I'll show you that let's map the route of inflammation. The lymphocyte, naive lymphocyte, they go to the lymph node, mesenteric lymph node, and they get activated out there. When they get activated out there, they follow a S1P gradient, and from where, following the S1P gradient, they go to the blood vessel. So if you have a blocker which is known as ozanimod, which is S1P modulator, receptor modulator, the lymphocytes will not be able to exit the lymph node. Even if they exit the lymph nodes from the blood vessels, they have to reach the lamina propria, that is the site of inflammation. And there you have a blocker for alpha 4 beta 7 because that is a receptor on lymphocyte which interacts with MATCAM and crosses the blood vessel. So you have vedolizumab out here. The activated lymphocytes, once they reach the lamina propria, they can diversify into Th1 or Th17 cells, release TNF alpha, which is a major cytokine, and you have the anti-TNF agents which will block it. At the same time, macrophage and the dendritic cells all also want to propel the Th1 and Th17 cells, so they'll be secreting IL-12 and IL-23. If you want to block the initiation by macrophage and dendritic cells, you have ustekinumab, which blocks IL-12 and IL-23. However, if you want the blockage to be very specific, that is IL-23, you have the IL-23 agents, that is the P19 blockers, risankizumab, guselkizumab, and mirikizumab. And if the lymphocyte, if you want to block anything inside the lymphocyte, the whole signaling cascade intracellularly, you have JAK kinase blockers, that is tofacitinib and upadacitinib. The latest out in this armamentarium or the arsenal is the P19 surgical strike, as we call it. Ustekinumab, as you know, is an IL-12/23 blocker. It blocks both IL-12 pathway as well as IL-23 pathway. So the thought came up, why not block only P19, which is a subunit of IL-23, block only the IL-23 pathway? Because it's quite possible that IL-12 needs to be preserved for critical anti-infection defenses. It may be useful actually. So with ustekinumab, you may be blocking a useful pathway and you may be blocking an inflammatory pathway. If you block only P19 or IL-23 inhibitors, then with these three agents, you'll be preserving IL-12. So as a result, you'll be preserving the good pathway. So came up the P19 surgical strike, and no wonder when you did randomized head-to-head trials, ustekinumab versus risankizumab, the sequence trial, it was seen that risankizumab was superior in terms of endoscopic remission. When you did the Galaxy trial, head-to-head trial, ustekinumab versus guselkumab, it was seen that guselkumab was superior in clinical remission as well as in endoscopic response. So IL-23 inhibitors are proving themselves to be superior to IL-12/23 blockers. Still more arsenal has to come up. I'm just introducing one major drone, I would call it. And this major, I call it a drone because it seems to hover over too many cells and seems to be blocking everything, something which we would all want to happen like. This is the TL1A cytokine, which interacts with DR3 or the death receptor 3. And this TL1A is secreted in many inflammatory cells, the endothelial cells, the dendritic cells, the macrophages, lymphocytes, innate cells, adaptive cells, and even the non-immune cells. And it acts on all kinds of Th1s, Th17, and also acts on the fibroblasts, so it controls inflammation. At the same time, it is anti-fibrotic. The names are obviously very Greek types, difficult to remember. I'm sure once they come up, we would find it easy to remember them. The fourth strategy, and this has been a major change in last 2 years only, that has been early offensive action. Where do you want to wait? Early institution of advanced therapy. And the swing has been, I think, because of one major study which came up from Cambridge that was around 2 years back, which is the profile study, which looked at patients with early newly diagnosed Crohn's disease within 1 month of onset. Steroid reduction was given for 2 weeks. So there are two arms, accelerated step up and top down. And in the step up arm, steroids are given followed by immunomodulators. And in the top down, infliximab was started along with immunomodulators. Not an evenly balanced study design, because in accelerated studies, step up, you were giving steroids too many times out there. But nevertheless, this was a large randomized controlled trial. And the interesting part was 85 to 88% of patients are having B1 disease. The median time from diagnosis to enrollment was only 14 days. So 85% of patients were inflammatory. Top-down therapy we mainly reserve for stricturing and penetrating disease. Here there were patients who had inflammatory disease, and the outcomes were equally spectacular. That is, when you look at sustained surgery-free and steroid-free remission, you find there's a delta of 64 points. That is a whooping delta. Endoscopic remission, quality of life, etc. Everything significant. In the B1 disease patients, the inflammatory Crohn's disease patients who are traditionally not considered for top-down therapy, to be given top-down therapy. Interestingly, the primary objective of this trial was not to look at top-down therapy, but to look at biomarkers. The randomization was on the basis of biomarkers, and it was seen that based on biomarkers, the difference was not significant. You would say that the adverse events were more in the top-down therapy. No, they were not. The adverse events were equal in both the arms. So this was a paradigm change which this trial suggested. That top-down treatment with combination of infliximab and immune modulator, since this trial used infliximab, so obviously they could only say about infliximab, should be adopted as a standard of care for most patients with newly diagnosed active Crohn's disease. Yet, remember, there is another entity which is known as mild CD, and you have to be very careful about that. So the early offensive strategy tells you that if you divide the patients according to mild Crohn's disease criteria or patients who have moderate to severe aggressive Crohn's disease, we would call any patient as having moderate to severe aggressive Crohn's disease, irrespective of being B1, B2, B3. That is, if they are B2, B3, fine. But if B1 with high inflammatory burden, deep ulcerations, high CRP, decreased albumin or severe disease activity, then it seems the world is definitely veering towards it that top-down therapy should be offered to these patients with newly diagnosed active Crohn's disease, but not for mild Crohn's disease. So comes up the fourth strategy for the war, that you want to prevent collateral damage. You don't want the civilians to get hurt out there. So out here for Crohn's disease, you want to identify mild Crohn's disease and treat it with the traditional step-up therapy. Don't be in a hurry to go in for treating them with advanced therapy. And I think there's a famous Chinese war wisdom lord, I would say, and he said very well, he will win who knows when to fight and when not to fight. So when not to fight in a case of Crohn's disease? There is an entity known as mild Crohn's disease. Mild Crohn's disease is something where a patient is ambulatory, tolerating oral intake, no fever, no tachycardia, no major weight loss, hemoglobin, albumin are normal, C-reactive protein slightly elevated, fecal calprotectin slightly elevated. You do a CT or colonoscopy, you find a single segment of ball or few aphthous ulcers, no penetrating disease, no stricturing disease. As Vishal showed you, this kind of entity also exists for ulcerative colitis. For Crohn's disease, also this kind of entity exists. And 20 to 30% of patients with Crohn's disease have a mild disease course, which is non-progressive and may not benefit from immunosuppressive therapy. So once you identify this phenotype, your job is that you can start budesonide for 8 weeks, taper it off, or you can give sulfasalazine for colonic Crohn's disease. Some of these, if they have a response, you can go in for azathioprine or methotrexate. Otherwise, for many of these, for maintenance, you may give just antidiarrheal activities or dietary modifications. Many of these patients are also maintained on 5-ASA. So should we do that or not? Because it seems to be frowned upon globally in the sense that guidelines, meta-analysis are very clear about it. Do not give 5-ASA. But there seems to be a wonderful gap between the evidence and practice, and not only you would say in developing countries, but in developed countries as well. If you look at various surveys from Australia, China, Korea, US, Germany, you find that 30 to 90% of gastroenterologists say that they have prescribed 5-ASA in patients with Crohn's disease. So one would say, let's not go against the guidelines, but at the same time, there is definitely room for thought based on real world evidence. And that is that 5-ASA can be maybe used in patients with mild Crohn's disease, colonic luminal disease, particularly that is mild Crohn's disease, or patients having terminal ileal ulcers, few aphthous ulcers in the small intestine. You would not like to continue 5-ASA once you have started advanced therapy or you find the disease is progressing. Another case of overtreatment, that is terminal ileitis. Again, we would call it a battle because kind of related to war and battle, because terminal ileitis is actually a battleground. There are a lot of immune cells out there. The microbiome stasis also starts occurring just because the ileocecal valve. So the landscape is fertile for skirmishes and battles out there. And like Panipat was a famous ground where 3 major battles were fought between 1500 to 1700. So just because it's a battleground, there are bound to be some kind of inflammation which may occur. Every inflammatory erosion or ulcer does not mean tuberculosis or Crohn's disease. So how do you decide which is worthy of being treated, which is not worthy of being treated? There's a simple algorithm for that. First of all, how common is terminal ileitis? Less than 1% of screening colonoscopies when you screen for CRC, but 79% of colon when you're doing it for symptoms. NSAID injection is the most common cause. So the moment you see it, ask for that history. Rule out acute infective ileitis. Once you have found terminal ileal ulcers and you find they are superficial ulcers, you have taken a biopsy which is non-contributory, they are incidentally found terminal ileal ulcers, you can safely follow them up. You may repeat a colonoscopy after 1 or 2 years, treat them symptomatically. Incidentally found terminal ileal ulcers which are superficial, biopsy non-contributing. However, if the patient is symptomatic, the terminal ulcers are superficial or deep, the biopsy has not shown any malignancy or eosinophilic esophagitis, it may be makes good sense to do a CT angiography or chest or a MRI, image the patient. Then there are 7 features. This is based on a bootstrapping technique. This algorithm has been evolved on the basis of around 134 patients. That is, if the patient has a history of GI bleed, weight loss, anemia, deep ulcers, granulomas on histology, long segment or involvement on CT, or necrotic lymph node, even if one of them is present, then you know that you're dealing with either tuberculosis and Crohn's, malignancy you have already excluded on biopsy, and here you may also think about doing capsule endoscopy. However, if none of them is present, then you can safely follow them up and give them symptomatic treatment. Don't be in a hurry to label them as Crohn's and start them on advanced therapy. Then comes the major chunk of war that you have started preparing for the war and all. How do you maneuver the terrain? That is, how do you decide to treat B2, B3, B1, B2, B3 perianal disease? The rules of the game are the agents we have already talked about. Vishal has talked about it. I have told you a little bit about it. High disease burden, you would like to use infliximab, adalimumab. Adalimumab is not a good drug for ulcerative colitis, but in Crohn's disease, it's as good, almost as good as infliximab. P19 inhibitors, guselkumab and risankizumab. JAK inhibitors, upadacitinib. Low disease burden, you would like to use ustekinumab, vedolizumab, or P19 inhibitor, that is mirikizumab. When it comes to safety, P19 or the IL-23 inhibitors have an excellent safety profile, as good, if not better, than ustekinumab or vedolizumab. So that is how you would picture the agents out there. Then the next thing is most effective first-line therapy for moderate to severe Crohn's disease. That would include anti-TNFs. Infliximab should always be combined with 6 to 12 months of azathioprine. Patients are intolerant to azathioprine, you give methotrexate. Adalimumab may or may not be combined with azathioprine. All the three P19 inhibitors, they are excellent first-line therapies. Ustekinumab can be used as first-line therapy. Upadacitinib can be used as first-line therapy. And vedolizumab can be used as first-line therapy if it's a low-burden disease. Which are the safest first-line therapies if somebody is elderly, comorbidities, coronary artery disease, demyelinating disease, etc. P19 inhibitors, all three of them have a good safety signal. Ustekinumab and vedolizumab, we know, have a good safety signal. The scenario changes if the patient has been already exposed to first-line therapy. In second line, what do you do? In second line, if the patient has failed anti-TNF, you have to just remember that the patient, you have to just check out whether the patient has any extraintestinal manifestation of fistula. Because if the patient has extraintestinal manifestation, then only JAK inhibitors or TNFs, anti-TNFs can be used. You have already used anti-TNFs, so best would be to use JAK inhibitors. Ustekinumab may be useful in patients with psoriatic arthritis. Anti-IL-23 may be useful in patients with fistula. If the patient does not have EIM or fistula, then obviously you can use anti-IL-23, JAKs, or ustekinumab. If the patient has failed ustekinumab, you can go for any therapy but vedolizumab. If the patient has failed vedolizumab, you can use for any of the therapy. In other words, what it tells you that anti-TNFs, if you have used first line, second line can be JAK inhibitors if the patient has EIM. If the patient does not have EIM, then you can use practically any agent except vedolizumab. Vedolizumab you can use in Crohn's disease when the disease burden is less, but may not be a great drug as a second line agent. What about small bowel stricture in Crohn's disease? The step that matters more than drug choice is confirm that there is something to treat. In other words, is there an inflammatory stricture or a fibrotic stricture? You have an MRI risk score based on the Strident study, which shows that if there's a pre-stenotic dilatation more than 30 millimeters, stricture length more than 50 millimeters, bowel wall thickness more than 10 millimeters, the score, give 1 point to each one of them. Score is more than 2, there's a less chance of response to advanced therapy. The score is less than 2, you will be very right in giving the patient anti-TNFs, and the best evidences for adalimumab in the form of randomized controlled trials. The other choices are infliximab, ustekinumab, IL-23 inhibitors, vedolizumab, upadacitinib. Upadacitinib and vedolizumab I put in the list. I'll tell you why. Adjunct therapy, very important out here, is endoscopic stricture management. You can do by balloon dilatation, stent placement, electroincision, or you have some drug-eluting stents which are coming, which can be used, but mainly it is balloon dilatation, stent placement, or electroincision. Parth has done a lot of work on it, and so here I put up a table from his review, which shows that when do you decide to dilate and when do you decide not to dilate, that is go for surgery. If the length of the stricture is more than 4 or 5 centimeters, more than 4 strictures, there's a suspicion of malignancy, go in for surgery. Or if 3 out of 4 risk factors are present, fistulizing disease, hugely dilatation before the stricture, suggesting that there's a lot of this thing, the dilatation is more than 5 centimeters, inflammatory burden is high, or anti-TNF exposure, the patient should be sent for surgery. However, if it is a mixed stricture or fibrotic stricture, less than 4 centimeters, less than 4 strictures, risk factors are low, then you may go in for balloon dilatation or stricturotomy, or at times can even place in a stent out here. Upadacitinib seems to be at present not useful in small bowel stricturing Crohn's disease. That is what the data suggests. So although we tend to use it for patients who do not have access to the more expensive therapy because we do not have a choice, but it is not recommended as a first line therapy for symptomatic stricturing disease. As the post hoc analysis data shows that anti-TNFs and IL-23 inhibitors, those ustekinumab, their efficacy rates are higher than upadacitinib. Upadacitinib has a very weak efficacy signal, and even in the pivotal trials, symptomatic obstructive Crohn's disease was never studied for upadacitinib. Perianal fistulizing Crohn's disease, infliximab still rules the roost, I would say, in the sense that it is considered absolutely the first-line therapy. Infliximab plus azathioprine plus ceton placement, all three of them. If the patient has a primary non-response to infliximab, that is with induction dosing not responding, you have a choice for ustekinumab, upadacitinib, guselkumab. Randomized control trial has come up for guselkumab and ustekinumab. If the patient has a secondary loss of response, after a few months of responding well, patient loses response, then you can again try adalimumab out here. It is not that the patient has lost response to infliximab, adalimumab can never be tried. Adalimumab is a good drug for Crohn's disease. So particularly in this setting of secondary loss of response, you may try. DEW 2026 this year, the fusion study came up which showed that guselkumab in a randomized control trial was found to be efficient for patients with perianal fistulizing disease. Another randomized control trial from the French group for ustekinumab shows that it is efficient again for patients with perianal Crohn's disease, much for patients who are anti-TNF naive, slightly less for anti-TNF refractory patients. You do get patients with only upper GI Crohn's disease. Only 2 to 10% of them have isolated choice, but they are very refractory to treatment. The first choice would remain infliximab and adalimumab. Add proton pump inhibitors. Remember, vedolizumab probably theoretically should not act in esophagus or stomach, so don't tend to use it because MADCAM receptors, which interact with alpha or beta 9 receptors on the lymphocyte, they are actually present mainly in the small intestine and large intestine. Few cases do come to tertiary centers of metastatic disease or vulvovaginal Crohn's disease. When we say metastatic Crohn's disease, it means granulomatous skin disease, non-contiguous with the GI tract. The best choices out here are again anti-TNF therapies, and you may have to give the dual therapies out there, that is combined two biologics out here. Upadacitinib, cyclosporin have also been found to be useful in this setting. Post-operative Crohn's disease. Does everybody need prophylaxis? You have to monitor everybody for prophylaxis, but everybody does not need prophylaxis. 70% of patients need prophylaxis. How do you decide which patient needs prophylaxis? You have the risk criteria. That is patients where you know this patient after surgery you have to start prophylaxis. That is any more than one, two or more factors out of these four. That is a patient is a smoker, is undergoing a second surgery, has a enteric fistula, perianal fistula. On resected specimen, there is myenteric plexitis or granuloma. And if the patient has these kind of high-risk features, the first-line therapy remains anti-TNF therapy. You can also try vedolizumab in this setting, ustekinumab, and upadacitinib. IL-23, we still have to get data. However, there are certain people where you can easily follow them up or may even give just azathioprine, and that is low risk. You do a colon if they have none of the risk factors. They have been diagnosed with Crohn's at more than 50 years of age, non-smoker, first surgery which was for a stricturing disease and not a fish-lying disease, long disease duration more than 10 years before surgery. There you do a colonoscopy at 6 months, can also do a fecal calprotectin and monitor these patients. Vedolizumab, I would say, as a second-line agent, or can also be used at times as a first-line agent, is because of the recent trial which came up, which is the Reprevio trial, which showed that patients who had at least one risk factor were randomly assigned within 4 weeks of surgery to vedolizumab, and it was seen that it was likely to prevent endoscopic recurrence, although in the sense the clinical recurrence was not significantly different. But remember, an interesting point out here is that induction regime was not given. And so in post-operative recurrence, if you're planning to use vedolizumab, you may not give induction regime and straight away start with maintenance regime. Patients are losing response. What do? Do you change drug or do you optimize them? If it is anti-TNF, add azathioprine. If azathioprine intolerant, add methotrexate. If we have the choice of doing therapeutic drug monitoring, best to do drug levels and antibody levels. However, many a times patients can't afford, or if for adalimumab it is not freely available, then you may escalate dose and see what is happening out here. Vedolizumab, patient is losing response. You can intensify the dose to 4 weekly instead of 8 weekly. The benefit is more in patients who had a primary more patients who have a secondary loss of response rather than primary non-response. Would azathioprine help? Yes, recent data suggests that azathioprine may help. Vishal was also sitting on the fence about it in terms of ulcerative colitis. So for Crohn's disease, the traditional view was no, but for Crohn's disease, recent data says that in such a setting, you may be right in adding azathioprine. Ustekinumab, escalate the dose to every 4 weeks if the patient has lost response. Still not responding, re-induce with a IV dose. Still not responding, then thereafter what you can do is that before you go over to IV maintenance dose, when you re-induce with the IV dose, here you can switch down to from 4 weekly maintenance to 8 weekly maintenance. And if there is partial response, then instead of a subcutaneous maintenance dose, you can move over to 130 milligram IV dose. Upadacitinib, it's not necessary that for Crohn's disease, induction dose has sacrosanct for 12 weeks. You can go up to 16 or 24 weeks if the patient is having a partial response. If the patient has had a response, you have decreased the drug to 15 or 30 milligram maintenance dose. You can easily go back to induction dose if the patient has lost the response. It's a typical switch on, switch off phenomena. It is an oral small molecule, not a protein, so no antibodies are found out there. Remember, amongst all this, thiaprins do have a role. Particularly, many of our patients cannot afford most of these therapies. Even upadacitinib is expensive for them. And this long-term data shows that thiopurines, both in ulcerative colitis and Crohn's disease, for a large number of patients, around 1,000 patients, 268 Crohn's, 722 ulcerative colitis, till 5 and 10 years, there was an excellent retention rate and effectiveness rate. 79%, 72% for ulcerative colitis, 68% for Crohn's disease, showing two things. Number one is if thiopurines start acting, the patients really do well. It's the initial period which is stormy, but once they get going, they really get going. Then they can go on for years. Second, it's not necessary that you need to stop them at 3 to 4 years. You can go according to case basis in such situations. Then comes the surgical strike. So obviously no war can be complete without a surgical strike. And for surgical strike in Crohn's disease, we have some landmark data which has come up. I would say a culmination of landmark data which has come up this year. And that is the LYRIC study. The 1 year came up, 5 year came up, and the 10-year has come up. So what is LYRIC study? It was a randomized controlled trial which looked at laparoscopic ileocecal resection versus patients who were continued on biologics. So this was the patients who were included with Crohn's disease with limited terminal ileal disease, less than 40 centimeter of terminal ileal involvement, non-structuring disease, failing to respond to steroids. Usually the next choice is what biologics. So here is, can you randomize them to surgery versus biologics and what happens? So three papers in Lancet Gastro have 2017, 20, 26. Excellent 10-year data. First year prospective data, next two papers retrospective data. First year data suggested surgery cheaper, quality of life comparable. Established surgery as a legitimate first-line option. 5-year data, both equal. Because half of infliximab patients needed surgical resection, half of resection patients needed medical therapy. But 10 years says that seems to be a benefit of surgery, but only in a subgroup. That subgroup is the young patients. For young patients, 20 years old and all, the delta was 30% for clinical remission if they underwent a ileocecal resection. So that tells you that yes, surgery is a legitimate first-line option and probably much better if it is performed in younger patients. Multi-domain operations, it's keystone of every war strategy and multidisciplinary team you cannot do today without. If you have to manage a patient of Crohn's disease, be very clear, it has to be a coordinated strike. Frontal assault like few years back would not help. You would end up either missing a diagnosis or you would end up in terms of only going from one medical therapy to another therapy. And while you're doing that, remember that in many patients you have to combine two advanced therapies because there is a therapeutic ceiling with monotherapy. Most of the advanced therapies, they have a clinical remission rate of 40%. If you want to increase it, then you have to combine two therapies. And it has been based on very good basic science data, which shows that most of the patients of Crohn's disease, when they're put on anti-TNF therapy, after a few months and all, in the non-responders, there's a change of the immune pathway. There's an immune invasion. These patients have upregulation of IL-23 and IL-17, and so they would respond better to IL-23 agents rather than to anti-TNF therapy anymore. So in other words, you not only may need to change therapy, you need to combine therapies. You have the famous Explorer trial, which is single-arm study, looked at 3 agents in combination, showing that in newly diagnosed Crohn's, yes, it seems to be beneficial. So it was kind of proof of concept. And today you have studies coming out from various centers across the country. This is one from Delhi, which shows that it is under review right now, abstract form. So this shows that there are in 35 patients or 34 patients, different combinations are used, but look at the effectiveness. If you look at non-response, it was 30%. In 70%, there was some other response, and these are very, very refractory patients. But comes with a note of caution because there were serious infections in 11%, and 5% patients or 6% of patients did develop TB out here. Surprise and simplicity is a very important strategy, and for Crohn's, the surprise and simplicity comes in the form of 2 concepts which are being readily embraced by every group across the world, and that is utilizing ultrasound as a modality, as a non-invasive modality of monitoring. Standard B mode, color Doppler, no contrast, no bowel preparation, no radiation, real-time bedside results. So many positive points. You can diagnose active disease. You can look at complications like strictures, fistulae, abscess. The scores can predict endoscopic activity, reduces repeat endoscopy. You can monitor these patients, and it's a point of care value. Non-invasive, low cost, you get your results immediately. They don't need contrast, except there are 2 selective extensions. That is, you may do a contrast enhanced ultrasound, which is an IV microbubble contrast, when you are not clear whether the structure is fibrotic or inflammatory. Or you can do a small bowel and oral contrast, SICUS, which is known as that you give oral peg leg 250 to 1000 ml. This is given if the loop is not seen well on the standard bowel ultrasound. You want to distend the lumen, or the loop is somewhere in the pelvic ileum or jejunum up, and you want to look at the stricture length, etc. Crohn's disease, in diet and Crohn's disease, we can go quite a lot about it, but I'll briefly touch it out here. And that is that for pediatric Crohn's disease, EEN is as good as steroids. For adults, Crohn's disease exclusion diet seems to work well, especially for mild to moderate patients. Patients who are in stable remission, again, Mediterranean pattern diet can be used. Ultra processed food should not be used. Low FODMAP diet in patients who have IBS symptoms. Texture modification in patients with fibrotic disease. But for moderate to severe disease, diet is adjunct only. Patients who are on biologicals, they have severe disease activity, adjunct exclusive enteral nutrition is a great strategy. It seems to work very well. And out here, amongst all the dietary choices, I would commend this meta-analysis led by Vishal Sharma, which clearly shows that Crohn's disease exclusion diet seems to work well for inducing remission in Crohn's disease, and also possibly to some extent to maintenance. And this is important because the world has been harping on Mediterranean diet, and Mediterranean diet is something which cannot be used globally and may have a cost issue, especially in India. So that is why I would say this meta-analysis is especially very important for our country. Finally, unity of command is necessary. Crohn's disease is not only about advanced therapy. The patients are with you for a lifetime. And there are certain treatable traits out here which you need to look at. And if I would enumerate the main treatable traits, that is bone health, mental health, nutritional health, screen for cancer, especially in Crohn's colitis, screen for colon cancer. And if they're on long-term advanced therapy, screen for lymphomas. Vaccinate all of them. Killed recombinant vaccine can be given 2 to 4 weeks before starting advanced therapy. It can be given concomitantly also if you have no window. Often you do not have a window. You have to give influenza, pneumococcal, hepatitis B, hepatitis A, herpes zoster, meningococcal, and human papillomavirus as per the gynecologist. And finally, for you want to predict and prevent, so some amount of intelligence gathering is required. For Crohn's campaign, there has been a lot of intelligence gathering which has been going on from last 10 years, I would say. None has proved to be fruitful, but the latest one seems to be hold a lot of promise, still to be proved in Indian ethnicity. And this is a paper from James Lee's group, and this is from multi-center study from UK, which looked at the genotype-phenotype association. In other words, they took up 43,000 patients of IBD. They found that 4.6% of them had a HLB-DR1 carriage. And irrespective of being Crohn's disease or ulcerative colitis, anybody who had HLA-DRB 10103 carriage, they had severe outcomes. So actually, this is the first comprehensive severity LLA that is associated with adverse outcomes. This tells you that especially in patients with English patient where the study was done, if this carriage is there, the advanced therapy should be immediately started. So the campaign in 2026 is we realize that as warfare has changed, as rules of engagement in warfare have changed, similarly for Crohn's, we have shifted from conventional to modern warfare. And now the rules of engagement include first the cautionary note. Not every fire in the gut is Crohn's. Please remember that, especially for our country, because there are many mimickers. Advanced therapy early in the course of disease seems to have caught everybody's imagination. Top-down therapy for all except mild Crohn's disease. Remember to pick up the mild Crohn's disease so that you do not treat everyone with the same hammer. Target to treat is an accepted strategy for Crohn's disease, if not for ulcerative colitis. Surgery is becoming a legitimate first-line therapy in patients with L1 disease. Non-invasive monitoring bowel ultrasound seems to be becoming gradually mandatory. Holistic care, again a major pillar and mandatory for the well-being of the patients, and that includes nutrition, mental health, vaccination, and bone health. With this, I would like to thank you all of you for your attention. Thank you so much.
I think Dr. Ajit would agree with me that very exhaustive, at the same time very explanatory and very exciting talk, both the speakers. And beneath, now in the modern warfare, this is going to be a totally different. I think your Crohn's, you had a kind of war area. Ajit, your comment, then we'll start the discussion with the.
Yeah, I think very nice lecture, Vineet, and you have emphasized, I think, very important issues that one should be very sure about the diagnosis of Crohn before really embarking on any kind of therapy. And second, you really recommended that it should be a more holistic approach. And it's very important to categorize the disease into mild or moderate to severe because our strategy differs a lot. I think with this, I mean, it's open to, we can go for discussion if you want us to ask questions to the
Yeah.
panelists or to the speakers. Today, we have the privilege of asking the questions to the speakers.
So first we'll start from Jill, and
Okay.
then Dr. Ajit. Then we'll have a panelist and everyone to ask. We'll go in the first round. I will start with Dr. Jill.
Yeah, great. I'll present a question to Dr. Sharma. At what point do you give up on mesalamine? So you talked about sort of mild to moderate disease, starting a patient with ulcerative colitis on a mesalamine. What is your time point for kind of measuring objective markers that they're responding, clinical response, and then when do you move on to more advanced therapies?
Yeah, I mean, so in mild to moderate ulcerative colitis, when we are using mesalamine, sometimes, you could have a response as early as few days, but certainly one would expect that you would have some amount of response by 3 to 4 weeks. And if you don't really have by that time, it's maybe time to reconsider. And especially if you are a worsening patient, then certainly you can reconsider early. Typically, you would have the full effect by maybe 8 to 12 weeks, but certainly by 4 weeks, you can take a call as to what is happening. And again, I'm again stressing that this is optimized ASAs where you have used the maximal dose and of course combined oral and local therapy as appropriate.
Is there any, so other than just assessing their clinical response, are you using fecal calprotectin? Are you using CRP? Are you using intestinal ultrasound in your practice? And sort of at what time point are you checking in?
Yeah, so for us, CRP and fecal calprotectin remain very important tools that we are using in day-to-day practice. We're also slowly transitioning to IBUS, and expertise is increasing across the country, including at our center. So we are transitioning to IBUS, but it's not yet become mainstream across the country.
Great.
You have a question to Dr. Vineet, Dr. Jill, for the Crohn's disease.
I do actually. You mentioned requiring sort of step-up therapy for mild Crohn's disease. There are some data that suggests that mild Crohn's disease, so that kind of the definition of mild Crohn's is really those patients that have sort of the aphthous ulcers in the terminal ileum, really asymptomatic, no markers of active inflammation like anemia or B12 deficiency, and asymptomatic. There's also sort of a thought to, maybe not even treating those patients and just proactively monitoring. So what is your take? Do you start them on therapy and see what happens? Do you have a discussion with the patient about whether they would want to be on therapy? Are they terribly concerned that this is, something that's going to progress? How do you approach those? I mean, it's really one of the hardest things because sometimes we feel like the medicines that we're prescribing is really to make us feel better, not necessarily the patient. So how do you approach the mild Crohn's patient?
So mild is first of all to classify them, that we are correct in terms of classifying them as mild Crohn's disease, be very sure about it. Secondly, if there is some amount of inflammation, you may start them on budesonide so as to curb the inflammation, and thereafter maintain them on symptomatic treatment in terms of fibers, isopgols, and in terms of antidiarrheals. However, if they require 1 or 2 courses of budesonide, sometimes you may have to go up to azathioprine. That is the maximum step up we may have to go. What happens is often in these patients, there is a kind of IBS overlap also. And because of the IBS overlap, and since each of the patients today, they know more about Crohn's disease than us, in the sense that because of the Google and because of Chat GPT and everything, so they're always very anxious about it. So in these some of these cases, even amitriptyline and etc. is useful. Yet at the same time, they feel more comfortable in being on some kind of therapy, even if it is 5 years or something like that. 5 years is another strategy I at least use a lot in patients with mild Crohn's disease, because it does seem to help them out there in terms of decreasing their symptoms.
Are you also incorporating sort of objective monitoring, fecal calprotectin, CRP, intestinal ultrasound to sort of monitor these patients
Not for,
pre and
not
post treatment?
for mild Crohn's disease, not all these things. Mild Crohn's
Mhm.
disease, simple CBC, serum albumin, ESR, CRP, and fecal calprotectin at times. If it is a
Right.
colon disease, then fecal calprotectin. If it is small bowel, few aphthous ulcers, then maybe even not that. So
Right.
not a very aggressive monitoring for mild Crohn's disease, the way we monitor all out for a patient with full-blown Crohn's disease.
Yeah.
Okay. And Dr. Ajit, you have a question to both
Yes.
Vishal and Vineet.
Yeah, question to both. I mean, I have a few questions. This is the first. I'll start. Vishal, you mentioned that the treatment for UC is becoming more complex. Do you feel the disease is also becoming more complex over the past 10 years? What is your concept? What is your impression that the disease is becoming more and more severe now? We never used to see such severe, complicated Crohn's. I would request we need to comment on this. You know, the complicated Crohn's and complicated ulcerative colitis, the number of patients what we have with ASUC. I feel that the disease is becoming more complex at the same time, as you said, that more and more treatment options are available. What are your comments?
Yeah. Before he answers, my gut feeling about the IBD in down south is we used to see ulcerative colitis, then little bit of aggressive disease. Now ulcerative colitis we see less often, less aggressive, but we see very complex Crohn's disease. In fact, very challenging. All kind of imaging need to be done, and whatever the armamentarium we have, that we need to do that. This is a feeling from our tertiary care center down south. I think I'm adding that also to answer this
Yeah.
both of you. Why there is a change in the spectrum of disease, or are we are biased in getting such patients only?
Vishal, you're going to answer
Yeah.
this?
So, no, I would echo what Sood sir has said, that it seems that, the disease is becoming more complex. From, a situation where almost all acute severe would respond to steroids. I mean, the response rates seem to be falling. And I agree that, wherever the South India goes, the North follows. And we are now, I mean, when we were training, hardly any Crohn's. And now a lot of Crohn's, even complex Crohn's with fistulizing, perianal fistulizing disease, non-responsive to the initial therapies. So obviously, I mean, the disease is becoming complex. I'm not very sure why it is happening. I don't know whether it is all us hybridologists together looking at it, making it more complex, or whether, there is a real change. Maybe some environmental factors are driving the increase in IBD and also maybe the complexity in IBD.
Yeah. Vineet, your answer is?
So disease is becoming more complex, I feel, because that's a kind of epidemiological phenomena. When a disease is on the rise, when it is on the upslope, the complexity of this disease increases. If you see cases from Africa, they're not that complex right now because the disease is on the lower slope. That is one. Secondly, in your case, I think what is happening is, since ulcerative colitis is easier to treat, number two, the awareness on how to treat because of your seminars. So a lot more people know what to do, what kind of therapies to do, so they treat them. But when it comes to Crohn's, they are very refractory, so then they send to the top doctor like you. That is the reason you see more of refractory Crohn's disease. Ulcerative colitis is easier to treat, and with their education efforts, people are already treating them well.
Vishal
Do
and
you
Vineet.
also, I have one question. Do you also see sort of a delay in diagnosis? I mean, do you think that's why patients are presenting with more severe, Crohn's involvement?
So we have a delay in diagnosis in Crohn's disease, and that is because of mimickers like TB and all. But at the same time, there are some patients where straight away they come with very aggressive disease. So it is not only a delay in diagnosis. That is not the only thing. I think it is something like, if you go to an area which has a low incidence of IBD, and if you go there and if you see cases, you do not find such complex cases. Whereas if you go to areas which have a higher incidence of IBD, you realize the cases are much more complex out there. The other take on that is that meta-analysis came up last year, which clearly showed that in patients who were on TNF therapy refractory, their TNF therapy was the first line of choice. So there, the vedolizumab was not acting at all, right? Because in the sense that at that time the vedolizumab stopped acting. Similarly, in patients who have had been treated with anti-TNF, as I showed you in the slide, the signal moves on to IL-23, and these patients will not be benefited by anti-TNF at all. This shows that if the patients are treated for a long period of time, which is happening in our case, that from last 5 to 10 years, we are overloading them with treatment. The moment you sequence the treatment, the immune evasion keeps on taking place, and immune signals, there is a lot of infidelity out there. In the sense, the same T regulatory FOXP3 cells, they can become inflammatory when treated over a period of time in an inflammatory milieu. So it's quite possible that this immune invasion is taking place because you have treated some of these patients with one drug, second drug, third drug, or something like that. And as a result, these patients stop responding at a certain period of time. Then there's another analysis available which shows that the first line therapy has a success rate of 60%, second line therapy has a success rate of 50%, third line therapy has a success rate of 40%. So obviously, to us from an outsider, the patient is becoming more and more complex. It is not that the patient is becoming more and more complex, the patient has stopped responding to the available therapies because the immune cells inside there, they are adjusting to it, and they are coming out with a new kind of bivalent immune cell which would not respond to the therapies, man-made therapies already available. So that is why you need TL1A today. Like TL1A, when it blocks so many, possibly it will.
Okay, now hereafter there are a lot of questions, brief question and brief answers. We start with the panelists now. Dr. Sarojini Parameswaran. Dr. Sarojini, while she's getting prepared for the question, I'll ask Dr. Satyamurthy to ask questions.
Yes, sir. Excellent presentations, both the speakers, sir. It is very difficult. We know that to condense within 30 minutes the entire IBD, because we see a lot of IBD conferences happening for 3 days, and excellent presentations, both of you, sir. So my question is, what happens if the oral small molecules like upadacitinib is being at the upfront in treating this moderate to severe Crohn's or ulcerative colitis, instead of going through step 1, step 2, step 3 failure? So directly we have the molecule now, we can prescribe that in ideal candidates. And what if it fails, the next one? Can the biologicals be restarted when an upadacitinib fails?
So the answer to this is that you will give upadacitinib only when it is indicated. Just because we have these agents and they are cheap doesn't mean that we do not lose our sense of responsibility. Both Vishal and me talked about the concept of over treatment, that let's not be in a hurry to start them. Be very sure that the patient needs them. Why? Because upadacitinib actually has a set of side effects which can include certain cardiac death, which can include thromboembolism. Herpes zoster is just a minor side effect for upadacitinib. Whereas that patient in ulcerative colitis may only require 5 ASA. 5 ASA does not have so many side effects. And for years, if we give upadacitinib, it may cause a lot of problems for the patient in terms of adverse events. Similarly, in Crohn's disease, if the patient is not respond, if the patient is moderate to severe, there we discuss. You can start any of the advanced therapy. You would be very right in terms of starting upadacitinib or infliximab, any one of them. If first line therapy fails, then you can go on to second line therapy. That is, if first line therapy is upadacitinib, infliximab, adalimumab, ustekinumab, or even vedolizumab, the second line you can go on to anti-TNF, or you can go on to upadacitinib or ustekinumab. So it is just a sequencing of therapies. It is just that in there we came up with caveats that vedolizumab is an excellent first line therapy for ulcerative colitis, but not a great second line therapy. But again, you can use it if you do not have any other choice. Similarly, for Crohn's disease, vedolizumab is a great first-line therapy for low-burden Crohn's disease, but not a great second-line agent. So these are some of the smaller caveats.
So you are thinking about complications and not to start Upada at the first line therapy unless you
Indicated.
see it in mild cases.
But
Okay.
we are recommending
It's
the
not
DVT
as Murthy said,
prophylaxis.
it's an ideal drug. It's not a Murthy ideal drug. You know, its response is different in small bowel Crohn's and colon disease, and it doesn't work in all patients. So still we
I
are
would
far away from uh, ideal drug.
I would
Ajit,
echo.
can you make it little more clear? It is the statement you made it.
The
Ajit?
response of Jackie's, and as far as Crohn's is concerned, as Vineet touched upon, that response in small bowel Crohn's is not as good as it is in the colon disease. And he showed
Colon
clearly
disease. Okay.
strictures, we don't waste time on really expecting good response with UPA in restricting Crohn's. So still we can't say that this drug will work in all cases. So we need to have a
Okay.
drug selection, which is very important for colon disease, colon Crohn's. The location L2, it has a better response compared to L1 disease. And for UC also, it doesn't work in all cases.
Crohn.
Every drug works in only 60% of cases.
Start with
On as a
mild.
rough
Every
rule of
day, I agree with you.
thumb.
Satya, you have a question to Vishal?
Me, yeah,
Or
Vishal.
we'll move on to Dr. Sarojini
No, no,
while you are getting ready.
sorry.
Dr.
Yeah,
No.
Dr.
I
Sarojini.
think both the lectures. I think both the lectures were very good. They covered most of the difficult scenarios. But I have two questions mainly to Dr. Ahuja, because as Dr. Chandrasekhar said, we don't see very difficult to treat UC here as much as really difficult to treat Crohn's. So do you ever face a scenario where in a patient with perianal fistulizing disease, you have treated with advanced therapy and you have achieved a mucosal response? You do a colonoscopy again and you do the markers, serological markers, and you've achieved mucosal healing, but the fistulas remain and they're really a problem. Do you face a scenario like that? And if so, is it a surgical problem and do we need to involve the surgeon more?
So if the fistula, there is a fistula remains, that the fish for the fistula, the gold standard is radiological healing. That on MRI should have a fibrotic tract. At times, what happens is the fistula tract may remain, but the patient is not symptomatic. That's a good clinical response. So there's nothing else to be done. However, if the fistula remains active, that means the drug is not fully responding. The patient is not responding fully to the drug in terms of there's a colonic response, but not a fistula. So here you have to see if there is any superimposed infection or abscess out there. If there's an abscess, you can drain it, or you can put in a ceton thread, which will help the advanced therapy to act by draining the infection from that side. If still it does not help, then you may have to change the therapy in terms of moving over to the next agent.
Then another question is in mild Crohn's, mild to moderate, where you have treated with budesonide and added azathioprine. And for many years, the patient comes to you and the all the serological, CRP is mildly elevated, she's asymptomatic. Is there a role for de-escalating, taking off the azathioprine, continuing only
So
pentasa?
as azathioprine, generally we don't take off unless until the patient has had a very prolonged azathioprine has been, you may say, we don't follow the 3 to 4 year rule. We go up to 7, 8, 10 years. Cases where we take off azathioprine is elderly who have a high risk of malignancy, or in young people, adolescents, we try not to put them on infliximab, azathioprine, especially in combination with the infliximab. Or if the otherwise we would continue them for 8 to 10 years, and then we would stop them after discussion with the patient if the patient is in clinical endoscopic remission. At the same time, you follow them up, and there's a 30 to 50% chance of relapse, and then you have to start another therapy. Earlier, we had no choice, but as Dr. Satyamurthy said about upadacitinib, their upadacitinib in such patient really helps. So there, Dr. Satyamurthy, you were right. Like in the sense that if you want to start upadacitinib and you have a choice of starting azathioprine, there you would be right. Okay, let's start upadacitinib out here. There, in those cases, you can do, because azathioprine also has a set of side effects. 30% of them are not able to have a set of side effects initial 3 months. Some of them do develop profound leukopenia despite any kind of testing, which can be life threatening. So there you may be, the risk benefit ratio may say, okay, start upadacitinib out here and go on for years with that.
I just
Okay.
want to highlight one thing
Yes.
that Dr. Ahuja mentioned. So the question was, about taking off the azathioprine in somebody whose biomarkers are okay and they're not having any symptoms. But the response was, make sure they're in endoscopic remission. There are a lot of patients, particularly with small bowel Crohn's disease, that actually don't have symptoms, even in the setting of active inflammation. So I think sometimes we lean too much on symptoms and really need to either use, intestinal ultrasound, some objective marker, or a repeat scope, or imaging if it's somewhere in the small bowel that we can't reach with the scope, but something to confirm that we actually, the medication is actually adequately treating the inflammation, because that's where we get sort of these progression to, strictures and fistulas and need for surgery.
Definitely, Jill. That's a very valid point. That small bowel, look at transmural healing by ultrasound or MRI.
Okay. Dr. Vinod, you have a question to both Dr. Sharma and Ahuja.
Sir, actually, both the lectures were very excellent, actually. And my question to Vinith Ahuja, sir, regarding tuberculosis in patients with coexisting tuberculosis and Crohn's disease, latent TB, whether will you continue anti-TNF concurrently, or will you stop it, or will you treat tuberculosis for a certain period of time and then you restart the anti-TNF? That is what first question.
So
And
you
second,
have to, so I'll answer this, then you can answer this. So you have to stop anti-TNF, you have to start anti-tubercular therapy. Then depending upon the disease, TB disease and the IBD disease, you can decide. Generally 4 to 8 weeks after ATT, you can restart anti-TNF. It is not that you have to change the drug. If sometimes if the patient does not have any IBD disease activity, you can even wait till complete resolution of tuberculosis. There are cases where within 1 or 2 weeks we have to start anti-TNF or therapy, some therapy along with for the patient, because the IBD may be very, very active. But the rule of the thumb is 4 to 8 weeks of ATT, patient showing the tuberculosis disease showing a response, that is the time then you may consider introducing advanced therapy again.
role of IGF, IGRA, like interferon gamma.
Study done from India shows that IGRA was not efficient in terms of differentiating tuberculosis from Crohn's disease.
Okay.
So it's for a TB endemic area. Although a meta-analysis from Hong Kong suggested that IGRA can be used, but in general, IGRA is a test for latent TB, and I don't think if IGRA is positive, that should help you to make a definitive diagnosis of TB at all. Or if IGRA is negative,
IGRA negative has got any connotation, or IGRA
it's just a
positive?
support. It's just a supportive evidence, like Montu is there. Montu positive or
can,
negative is
then
just a supportive evidence. So
you need not do in all cases IGRA, or still you want us to do?
we do both Montu and IGRA, because in the sense that we feel that investing another 1,000 rupees is not bad for the patient in terms of if we can prevent TB, and if any one of them is positive, and we can give them latent TB prophylaxis. I'm not sure if Vishal would agree with me. Maybe he would say that do only one of them. But at our center, we do both of them, including HRCT chest.
What if
We
visa becomes
do
positive?
both. We do both, and we do HRCT only in selected patients, maybe admitted patients. But certainly we do a chest X-ray, we do a Montu, we do an IGRA.
So one
Okay.
more question to Vishal, sir.
Satya, you have a question to ask?
Yes, sir.
Yeah,
What
this one
if-
is regarding
what-
appendectomy. Appendectomy in patients with ulcerative colitis. Sir has told that there is improvement in the remission. So I just want to want to know very curious to know what is the rationale behind that.
No, I mean, there is obviously, I mean, even in epidemiological studies, it has been shown that appendectomy is protective for ulcerative colitis. And although we don't know the exact way it works, but apparently Christiana Buskins and their group have shown through a cure trial and through COSTA, and I think they're doing a global study, another new study, where they are again looking at appendectomy globally. And at least whatever data they have generated, and this is again multi-center data, it suggests that it, number one, reduces flares and even seems to work in active IBD, active ulcerative colitis.
That is a statement need to be begun very, very carefully and start everyone doing appendectomy.
Gents will be very happy.
So, moreover,
So-
most of the Crohn's disease at one time or other in the history says that they have undergone appendectomy.
Yes, sir.
So it
So
is
the
different
first thing,
for Crohn's,
It is
different for
different.
Crohn's and different for ulcerative. Crohn's, you would never do appendectomy. Ulcerative colitis, you can do appendectomy. At AIMS, we recently finished a case series of 8 cases where appendectomy was done in patients with distal colitis, mild to moderate disease. 6 out of those 8 showed a response till 24 weeks.
You mean prophylactic appendectomy? If there is no
No, they
appendectomy.
had mild to moderate disease, so they were offered appendectomy as a choice. And 6 out of those 8 patients showed a
So that
response.
statement is so vital, important thing. The
So
whole
the echo
country-
consensus which Vishal showed with 100% agreement, that statement is that in lap appendectomy may be considered as an option in refractory patients with mild to moderate ulcerative colitis. And I think in the subsequently it is written that may be possibly more for distal colitis rather than pancolitis. Would that be
Because
correct, Vishal?
pancolitis does not get complicated. Suppose if you do lap appendectomy and
Yeah.
you have a cecal disease, very viable, I mean, the disease very severe.
Yeah,
I
so
just
I
want
think-
to know, I want to dilate upon that. You now, despite advanced therapy in left-sided colitis, you would like to do appendectomy. No? This is what you mean. Okay. We have 2 PG faculty there now, Dr. Bala and Dr. Sendil from Coimbatore.
Yes, sir.
From medical. You have a question to our speaker?
Yes, sir. I have a question, sir. Yes, sir.
Yes.
Sir, in a patient with visualizing Crohn's disease who were on infliximab and azathioprine, if that patient developed a lymphoma, who were on a remission, in those situations, what would your preferred strategy for treating this Crohn's disease? Whether we can reintroduce this infliximab
No, you
or
can.
azathioprine?
Infliximab, the only cancer situation today where you cannot introduce infliximab is lymphoma and melanoma. The earlier rule was that you wait for 2 to 5 years after any cancer before introducing infliximab. Now it has been seen that infliximab, vedolizumab, ustekinumab, you can start even immediately after chemotherapy, or even at case-to-case basis, even when the patient is undergoing chemotherapy. However, in a case of lymphoma and melanoma, you will use vedolizumab, ustekinumab, but not infliximab. Infliximab is clearly contraindicated if the patient has lymphoma or melanoma.
Okay.
Sir, I have a question, sir.
Jayant, please tell me.
Yes, sir. Sir, my question is to Professor Vineet Ahuja, sir. Sir, in Ranchi, sir, we are going to start, sir, intestinal ultrasound in our institute, and one of our consultants also got trained. So, sir, actually, at what time we should do intestinal ultrasound in ulcerative colitis and Crohn's disease? At what phase we can advise, sir?
So it can be done at any time, initial diagnosis when you're diagnosing. Then when you want to monitor the patient, when the patient is on treatment, you want to check the patient has come to the OPD for the response or not. If the patient is having any kind of complication, then you can do that. that you can do that. So it's a point of care test at diagnosis, monitoring, looking for complications. Anytime it can be done. It is like in the sense that you would like to do colonoscopy whenever you would want to do a colonoscopy or a fecal calprotectin or a CT scan. In any of these three settings, you can do ultrasound. That is the beauty of it.
Okay.
Thank you,
There's one more PG faculty, doctor from Coimbatore Medical College. You have a question to ask Dr. Agujan Sharma?
Yes, sir. Sir,
Yes.
actually,
Introduce yourself and introduce yourself. You're not seen.
sir,
Okay.
myself, Dr. K. Sandil Kumar, final year
Okay.
postgraduate, Coimbatore Medical College, sir.
Yes, please ask question.
Sir, 40-year-old female patient, sir, no comorbidities. We have ruled out TB, sir. Patient was diagnosed as recently IBD UC, and we have done a chest X-ray, Mantos and IGRA, all came as negative, and we started infliximab, sir. After completing 2 doses of infliximab, patient developed a disseminated TB, sir. So how we have to proceed with this case, sir?
Okay. Vishal?
Yeah, so this goes on to show that uh, in spite of our testing for latent TB, sometimes still TB will develop.
But CT chest was not done here, Vishal. CT chest was not done. That is another thing it shows.
Yeah, you
again. So again, CT chest is basically not for latent TB. You would agree that it is basically for either past TB or some active TB.
So, but for past TB, we advocate that you give chemoprophylaxis, even if you get any evidence of old calcification. So that is the thing I want to bring up out here, that where CT becomes important. Now you please proceed.
And again, so TB can develop, and obviously you will have to stop anti-TNF therapy at this moment and treat for tuberculosis.
Okay, that means you have to be a little more aggressive in investigating to identify latent tuberculosis. I think I would agree with you. I would like to do all three. I don't want to take a chance that CCT. Then I would like to do the GRA and Manto. Then I will carefully assess the historical evaluation also. Otherwise, the overt and the kind of tuberculosis you are telling is horrifying.
And
So
if possible, repeat it also after 1 year if the patient continues to take treatment, at least the MON2 or the IGRA and a chest X-ray.
I agree with you, Satya. 3 days conference, we are truncated to 1 hour. So there is no end for the question. Now, for last 5 minutes is mine. I want to ask very pointed question, very brief answer. Ajit, you are the founder of Colitis Crohn disease. When did you develop interest and how? Quick question. In IBD, I'm not asking other interest.
I think it goes back to 1985 or 86 when I was doing actually MD. My thesis was on ulcerative colitis. And just imagine, I'm still stuck on to ulcerative colitis since that time.
Oh, you are stuck up, you're almost married to ulcerative colitis. So your thesis made you the way. Vishal, when did you develop interest in IBD?
So initially I used to work in pancreas, but I had an opportunity to work on TB guidelines with Professor Deepak Bhasin and Professor Vineet Ahuja. And that was the time I got interested in luminal gastroenterology.
Okay. So your thesis and your thing on guidelines, so you abandoned pancreas.
Yes.
Okay, right. Vineet, your story about when did you develop interest?
So I think when I joined as assistant professor, I was working on Helicobacter pylori. I was told that I could work only in luminal gastroenterology. So I was working on Helicobacter pylori. Then I realized there was nothing left in Helicobacter pylori after pylori by that time, 2001 or so. So then I realized that IBD seems to be a very interesting field with a lot of immunology at that time, and immunology and the other things like it.
All of you by chance you got into that, no?
Yeah, by chance.
One is thesis, another one guidelines. There nothing left in luminal other than okay.
No, but after that, the field was so interesting that we stuck to it.
I think.
And at that time, when I joined, when I said that I would do only IBD in 2003 or something like that, everybody laughed at me and said that maybe this man has lost his mind. That in the sense that he is going to do IBD, there's not much IBD seen, and there's only steroids to be given or something like that. Infliximab had just come out.
Professor
today-
Jill, when did you yeah, sorry. You come on to
that's it.
complete. Dr. Jill, when did you develop or why? I mean, well, not why, I'm asking how.
So I fell in love with inflammatory bowel disease during my GI fellowship. It actually hadn't really been on my radar. My first publication was looking at the benefits of liver biopsy for fatty liver disease. And I realized I didn't like that. But then I rotated through an IBD clinic and I just really loved sort of the spectrum of the patients. I mean, you get very young patients, you get very old patients, you take care of them when they feel well, you take care of them when they're sick, and you get them through marriages and pregnancies and all kinds of sort of life events. So you have an opportunity to develop long-term relationships and really get to know the patients. And so, that's the
managing
piece that I really
IBD
love.
clinic and you are developing interest.
I
Sarojini,
think it's also one of the areas where we actually get to make people feel better. You can't do that with a lot of other areas of medicine, and we actually get to, people can forget that they have IBD when they feel really well. So I love that part too.
very gratifying.
Yes.
Okay. Sarojini, when did you develop interest?
So, I mean, I think like all the others started off with something else first. In hepatology, if you remember, I was with the transplant team initially, but I didn't like the transplant scene so much. So I opted out. And then I found an interest in IBD.
So you opted out and selected the better one, you thought, according to you.
Yeah,
Satya, you want to be labeled as IBD man?
Yeah, definitely. As the cases
So
increases,
please note this. Huh? I want my colleague to
during
note
my
this.
post-graduation 10 years ago, we have not seen such cases. Now, per day, we are having referral cases of complicated IBD. So, it is mandatory for every gastroenterologist to be an expert and be updated with what is happening. And we need to follow all the latest updates in treating these
Okay,
patients.
so you want to be included.
Yeah,
Ajit
it's
and
time
Vishal
to
and
have.
Vinit, you
Yeah.
have one more IBD man from down south from my unit. Not down, you can interest on him some project also.
Yeah, I think it's time to have
How did you
IBD.
develop interest? Ajit, you please tell me.
Yeah, I said just one line that IBD as a subspecialty, I think it's time now. It's picking up as a subspecialty like pancreas or liver or endoscopy, as you said.
The only complaint I used to have is most of the patient they can see in 10 to 15 minutes. IBD, when the patient comes, they spend around 30 to 45 minutes. So much involved. So when I asked in the OP stack up, and they asked him, no, sir, he's seeing a thick file of luminal IBD patient. Anyhow, that is. Vinod, how common there and how did you develop interest in IBD?
Yeah, actually, I mean, right from my post graduation, actually, I'm interested in IBDs. Actually, now we started seeing more and more cases. Actually, people who are traveling abroad, actually, they come with from the rural areas, probably because of the change in the dietary habits. Actually, from rural cultural diet, they are going and abroad and they are taking a fully westernized diet. So, more of such patients we come across, and probably that diet probably is making a major problem with the
Okay, diet and microbiota changing,
microbiota and
foreign
other.
travel, and you're practicing more number of cases made you to.
Even here, rural area, when they are going for urban diet, they are developing these problems. So
Okay.
actually, diet has to be given.
Now I have only 2 minutes. What is the non-medical book you have read recently, Dr. Jill?
I always have 2 or 3 books in rotation. So I'm reading a book called Bragging Better, which is about how to self-promote. And then I also am reading a graphic novel series called Tokyo Ghoul that my son and I are reading together. So
Okay, right. Vinit, what is the book you have read?
I'm
Non-medical.
reading The Golden Road, William Dalrymple. That's a beautiful account of
So how do you relax treating IBD, I think, no? Ajit, what non-medical book you read?
I
Yes,
just
don't have time.
I just follow sports. I don't really read.
He watches all
I just
sports.
follow sports.
He will not miss any match. Dr. Sood will not miss any sports.
Okay. Then Vishal, what is the non-medical book you read?
I'm interested in wars, so I read
Oh,
Operation Sindoor.
okay, right. And Sarojini?
I'm actually part of a book club. We meet every month. So
Oh,
tomorrow is the next meeting. So I'm
Oh.
reading a book. We read the book called Tomorrow and Tomorrow and Tomorrow. It's
Oh my
about.
God. Very good. Satya, don't curse me that I'm not giving time to read any book.
Yes, sir. The Tamil novel Ponniyin Selvan, a 5-volume book.
Yeah.
Last time also you said the same thing.
Same thing, I couldn't complete. It's a 5-volume book.
It's 5
Okay. Vinod?
Sir, I'm interested in stock market, so probably I'm reading financial books.
Okay, the last question of the day is, who is a hero? Dr. Jill.
I would probably go with Dr. John Valentine was actually the person who got me interested in IBD and really was a great clinician and cared for his patients. So he was a great role model.
Okay, you are a good mentee. So
Yes.
remember him. Beneath, who is your hero?
Who's my hero? Apart from parents, you mean to say?
Yeah. No. Parents, everyone. Parents, everyone, brothers or friends. Who
There
is
are
your hero?
too many heroes. Difficult to decide, but I'll
No,
start.
at least tell one or two, three.
Okay.
Professional hero, non-prof. I
Ah.
mean, outside profession.
So professional hero, Dr. Chawla, Dr. R.K. Tandon, Dr. M.P. Sharma, Dr. Acharya.
You told all the office.
No, not all the ones who have
Okay,
influenced me
right.
at each and
Okay,
every
right.
step. Like, yeah.
Okay, Ajit, your hero is?
I really admire Prime Minister Modi.
Okay, right. And Vishal?
So I would say my head during my MD medicine, Professor Dwivedi,
Professor?
and Professor Sridhar Dwivedi from
Okay.
UCMS, and amongst political personalities, probably Lal Bahadur Shastri.
Okay, right. You are from Allahabad?
No, sir.
Okay.
I'm from Himachal.
Sarojini, who is your hero?
Mine professionally is not a gastroenterologist, but Dr. M.K. Mani, nephrologist.
Okay,
He's
right.
been really a role model for me.
Yeah, role model. That's good.
Integrity and intelligence, everything.
Satya, who is your hero?
Obviously, it's you, sir, my mentor.
Because next tomorrow he has to come here. No, I'm
Good
just telling the
answer.
lighter sense. Okay.
Sir. In screens, it is the universal hero Kamala Hassan.
Okay, right. Very good. And Vinod, who is your hero?
My hero will be like Professor Nagi Reddy, sir, and Professor TSC.
Oh, you want to have two professionals.
Yes, sir.
Okay, now, ladies and gentlemen, it's a fantastic meeting. We were thoroughly got drowned in the kind of knowledge in ulcerative colitis and the Crohn's disease. Any number of time you listen to both of them, you always learn a lot of new things. So, and ably moderated by Dr. Jill and Dr. Ajit Sood, and we had a great panel, the Sarojini, Satya, and Vinod, and two PG faculty. It's a fantastic meeting. And I must congratulate the delegates who have logged in from all over the world. It is almost going beyond 500. So we are very successful, and you must be grateful. I'll convey this message to American College of Gastroenterology. You can get it in after 72 hours in YouTube. All the discussion will be there.
When will the questions be answered? There were a lot of questions.
Yeah. If you tell them that, I will put you as a question panelist for you. I will send all the question to you because there is no time. Even 2 hours not enough. I think we will carry on this question at a later date in another seminar on IBD. Okay, but all the thing you can see it in the YouTube. Hope you enjoyed it. It was very inspiring, knowledgeable, and it's sharing so much of your life experiences also. Thank you, Professor Jill, coming, logging from all the way from USA, and Ajit. And despite this is the first time I've seen outside the clinic in the evening, Ajit, and very remarkable, and Vishal and Vinod, you did a fantastic job. I see the panel, all the three panels enjoyed it. Thank you very much.
Thank you
Thank you so
for.
much. Thank you so much.
Thank you.
That was excellent.